Thank you very much, Mike. And thank you all for being here today. It's a great honor for me to be here, and I appreciate your presence today. I'd like to thank the organizing committee as well as Mike, and particularly Dr. Jensen. Thank you so much, Ole, for inviting me as well. And Dr. Jensen, as you all know, is an incredible clinician, but he's also a great scientist, and he's a great thinker, as Mike said. He really considers different issues, and he's always been on the forefront of everything that he does. He's a great businessman, entrepreneur, but he's a really great thinker, and he gives us that perspective. And I thank him this morning for talking about the perspective. And so one of the things that I would like to give him credit for is making this opening session about choosing an implant. Because as it turns out, your choice in what type of implant you put in your patient makes a big difference. And so I want to start with this data that just came out recently. This is a systematic review, meta-analysis of over 45,000 implants. It turns out it's from a consensus conference that the AO put on and published this past summer. And when you look at these 4 different types of implants, you can see that the top 2 lose about 1 millimeter of bone after about 5 years or greater than 5 years. What's a little disturbing about those top 2 curves is that it's on an upward incline. In other words, it's progressive bone loss. And we don't know if after 5 years it's going to continue to lose bone or not. But if you look at the bottom 2 implants, you're looking at pretty stable bone around those implants. So those lines are kind of flat. It's not going up like the top 2 lines. So I would ask you, when you're making a choice of an implant, which one do you want to put in your patient's mouth? One that's going to lose about 1 millimeter of bone around it, or one that's going to be stable and maybe 40% of that bone loss? And this is data from over 45,000 implants. So I think you can trust that these lines are pretty accurate. So if you're going to put an implant in your spouse or your mother or your father, are you going to choose one that's going to lose 1 millimeter of bone around it? Or are you going to choose one that loses much less than that? It's your choice, right? And so you need to think about that because it raises questions. Which one am I going to use? And does it disturb you that you're losing bone up to 1 millimeter with the progressive loss over time? Because isn't the purpose of osseointegration, right? We want as much bone around the implant as you can possibly get, but yet by your choice of choosing one implant over another, you're losing bone from the get-go simply by your choice. So the question is, why are these different? Why are 2 of these implants losing bone and the other 2 more stable? Now, we've had a long time in implant dentistry now, 30, 40 years to get this figured out. And there's a lot of data now. Now, the top 2 implants, the top one there is the external hex implant, machined implant with an external hex on the top of it. And the bottom implant down there is a tissue level implant, an implant that goes from inside the body to outside the body in one piece. It's one piece of titanium. Why is there a difference? So I think that's an important question. And I would say we need to wake up in implant dentistry because there's tons of data that tell us why these are different. So let's think about a little bit of that. This paper is, unfortunately, Ed and Dane are in the AO. This is from the AO consensus paper, and these are very smart people that wrote this paper. But it was disappointing to me that they didn't discuss the differences between those implants and why that occurred. And I don't understand that when you publish this kind of paper. They talk about, in the conclusion, the configuration of the implant abutment interface has an effect, obviously, on marginal bone loss. And these changes occur over time, but they didn't really talk about in this paper why one is up here and 2 are down here. But we have data to talk about that. These are vastly different. And this is your choice of making a choice. But I think when we talk about implants, we need to think about implants, and Dr. Jensen showed this very well. There are three factors that you can think about related to any device you put in the oral cavity. And Ole mentioned this. Implant components are foreign bodies, just like any other part of dentistry, a denture or partial denture, crown or bridge. All of these develop plaque, biofilm. And we know that plaque biofilm initiates a host reaction with inflammation. It's crystal clear. There's not one device we put in the mouth that doesn't get plaque on it that develops the host inflammation. When I look at implant designs, I see really three basic types. There's the tissue level implant, there's the bone level implant, that middle one there, and that's one with an external hex on it, bone level. The top of the implant is at the bone crest. And then there's a platform switched where the configuration is a little bit different because the abutment diameter is smaller than the implant diameter at the top, right? So we have a different morphology or architecture there at the top of the implant. All the different implant companies make these different types of implants. You can see BioHorizons here makes all three types of implants. You can see Dentsply makes all three types of implants as well. Noble Biocare makes two of the three types. And Straumann makes two of the three types. So you have a choice. If you look at the different implant companies, you have a choice of what type of implant you want to put in your patient. Many choices. I began looking at tissue level implants over 30 years ago. And when I looked at these implants, I noticed that the tissue level implant, which is a solid piece of titanium, it has a rough surface in the osseous part and a smooth surface above it, but there's no microgap or interface between those components. It's just different surface properties. And I thought that was kind of similar to the natural tooth, because if you look at the natural tooth is a one part or a one piece implant that goes from inside the body to outside the body. And as a periodontist, I was interested in the soft tissues. A lot of people were doing osseointegration at that time. I was interested in the soft tissues. And one of the features of around a tooth is there's a biologic width of connective tissue and epithelium. So we simply asked the question, is that the same around a tissue level implant? Because it looked like histologically it was very similar. So we published a paper a number of years ago that looked at the biologic width around tissue level implants. And what Gargiulio showed us around the dentogingival junction with the sulcus step, epithelium, and connective tissue, we looked at that around these tissue level implants and made those same linear dimensions of epithelium and connective tissue. And we showed basically there was same type of situation. In other words, the host responded in a similar way as what happened around the natural tooth. So when I started looking at this, we were looking at the tissue level implants, but the predominant implant that was placed in people's mouths at that time was this machined implant with an external hex top to it, the implant on your right. And when I looked at those histological specimens and looked at the radiographs, we always saw that the bone went down to the level of the first thread, right? The level of the first thread. And Albertson and Zarb and Worthington and Erickson in 1986 published on this and said the success criteria for these implants are that you're going to lose 1.5 millimeters of bone around the implant in the first year, and then it's going to be 0.2 of a millimeter after that or less. But when I looked at those specimens, it looked very different to me than the tissue level implant. The other thing that actually we observed was that the epithelium always went down to the level of the implant in the bone level implant on the right. The epithelium always went past that interface or microgap. I'll use those terms interchangeably, interface or microgap. But the epithelium always went past that. The host always responded by that epithelium going beyond the interface. And then the bone always went down to that level of the first thread. So why is that? I made that observation 30 some years ago. The data I just showed you from the AO reinforced that these are different, that there's something different between these types of implants. So the question is why? And as a scientist, if you want to try to understand what the differences are, you set up an experimental model system where you try to reproduce both situations, and then that can give you some clues as to why they're different. So we did an experiment where we looked at crestal bone changes around different types of implants. So the first one was, could we take a single piece of titanium, put it in bone, do histology on it, and recreate what was happening around a tissue level implant? And I'm going to show you a high magnification of the histology here. And I think what you'll see is a very nice specimen, very healthy tissues. You've got on the top there the oral epithelium with the reedy pegs at the top. You've got your junctional epithelium all going down to that first arrow, which is the apical extension of the junctional epithelium. And then you've got the connective tissue. But put in your minds, take a little mental picture of what that connective tissue looks like. It's very healthy tissue, right? And that's what we saw around the tissue level implants. Now, if we took a radiograph every month after we put these implants in the mouth, and what you see is that the bone level didn't change across that 6 months that we had these implants in the bone. So you put this tissue level implant in, you've got healthy connective tissue, the bone doesn't change. So then we said, okay, let's take the same implant, but let's cut it in half. So we have an abutment and an implant. And what we're going to do in this case is we're going to screw the two together as a single implant, and we're going to put it in the bone, and we're going to wait 6 months and see what happens. Now, on the right over there is the histology. Now, let's take a look and see what we see histologically on this type of situation. What you see is that the epithelium has gone past the interface. It's gone past the top of the implant where the microgap is. That's what that black arrow is. That's where the interface or microgap is between the top of the implant and where the abutment was. And you see all these blue and black dots. Those are inflammatory cells. So the epithelium is beyond, and there's bone loss about 1.5 to 2 millimeters. So what we said here is what the picture was, and BC on the left there is the bone crest, MG is the microgap, and what you see and what we observed was that there was quick bone loss. That bone loss didn't start and go gradually, it happened quickly. So it happened within a month, and then it became very stable. So this is kind of what was being observed around the Brannemark type implant. Quick bone loss, Albertsons are 1.5 millimeters, and then it becomes stable. And that's exactly what we were able to create around this implant. Now, as it turned out, when these implants were being done early on, of course, Dr. Brannemark told us, put the implant in the bone, wait 4 to 6 months, come back and do a second stage surgery and put the abutment on top. So that's what we did around these implants. We took just the implant, we took the abutment off, put the implant in the animal. We waited 3 months, then we came back and did a second stage surgery and put the abutment on top. And then we did histology. And you can see if we follow what happens radiographically, for the first 3 months, nothing happened when we put the implant in. But immediately when we put a second stage surgery and put the abutment on top of the implant, we saw this rapid bone loss, and then it was stable. So what's going on there? Why is this occurring? Obviously, the bone loss is associated with abutment connection. Now, notice also the first 3 months, nothing happened. If you read the literature, some people will say, well, that marginal bone loss is due to the osteotomy. When you make an osteotomy in the bone, you're going to create bone loss. But if you look at the first 3 months, we did an osteotomy at baseline, there's no bone loss. That's really BS. Okay, that'd be nice. BS. It's BS. An osteotomy doesn't cause bone loss. You see the first 3 months, Implant's very happy in the bone. There's no bone loss there. It wasn't until second stage surgery we created a microgap that we saw it. So this association of bone loss is strongly associated with the abutment connection. So we said, okay, what happens if we move the top of the implant 1 millimeter above the bone crest? What's going to happen if we move that microgap or interface away from the bone surface? And what we saw there in this picture is that there's less bone loss around the implant. If you look at the microgap 1 millimeter above the bone crest, you're still about 2 millimeters away from the top of the implant. But again, for the first 3 months, no bone loss, right? The osteotomy did not cause bone loss, but then there's 2 millimeters. So we said, okay, there's still a strong association with abutment connection and creation of an interface. So we said, what happens if we take the top of the implant and we move it 1 millimeter below the bone? What's going to happen then? We move it below the bone. And this is what our results were. What happened when you put the implant below the bone 1 millimeter, the bone starts growing over the top of the implant, right? Between 2 and 3 months, you see the bone growing over it. And that happened a lot to us when we placed the implants deep into bone, because it's a titanium implant and the bone grows closely to it. And so that's what we saw. Again, the osteotomy had no effect. Bone grows over the implant, but as soon as we do second stage surgery, boom, we lost bone and we lost it quickly. And then it becomes stabilized. So there's a clear association with the creation of an interface or microgap at the top of the implant and bone loss. So I tried to make this into a diagram that was easy to understand, and that, again, your choice makes a difference of where the bone's going to be. How you put your implants in is going to make a difference. If you put the top of the implant above the bone crest level, 1.5 to 2 millimeters, you're not going to see any bone loss. But if you decide to put your implant at or below the bone level, the top of the implant, the result is going to be 1.5 to 2 millimeters of bone, just like Alberts and Zarb told us. It's not the osteotomy that causes that bone loss. That's not the answer. You already saw good data that shows that's not true. If you read the literature, some people talk about physiologic bone resorption. Again, that's another BS term, physiologic bone resorption. There's no such thing as that, right? I think every one of you sitting in here are pretty physiological. If there's physiologic bone resorption going on, then you must be shrinking, right? Because bone resorption is not physiological, right? Bone resorption is pathological, right? We don't get bone loss without a pathological process, right? You probably remember that bone metabolism is a coupled process. That's how we control calcium in our bodies, right? We have osteoclast, resorb bone, resorption lacunae, recorbs bone. You get calcium release, but then the osteoblast fills in that resorption area. So bone metabolism is a coupled process. If you're losing bone, that's pathological. And it's time that we admit that when we have an interface at the bone crest level with a big interface, we're going to get pathological or bone loss, resorption. Now, does this happen? That was in an animal experiment model system. We were able to create what happened on tissue level implants, what happened on the Bradmark type bone level implant, what happens in patients. This was a study done a number of years ago. Danny Boozer and Klaus Lang put in about 67 patients. They put in 97 implants. These were tissue level implants. They put these in the late 80s and followed them up for 8 years. So this is the results of that. And you see that when there's a tissue level implant, and remember this implant has about a 2.8 millimeter polished collar, and you follow the bone level over time there in these 97 implants, the bone doesn't do anything because the interface, that white line up there, the interface white arrow, is way above the bone. And it just shows you exactly in patients what happened in our experimental model system. Now, we also did an experiment in San Antonio where I put implants in 42 patients, and we followed them over 5 years. And so I had a graduate student go in and look at the bone level around the implants. And I entitled this, the initial implant position determines the amount of bone loss. And what I'll tell you in advance is that the closer the top of the implant is to the bone, the more bone loss you're going to get. Okay, this is a phenomenon. If put the top of the implant further away, you're going to get less bone resorption. So just to quickly go through some of these pictures, this was, I treated 27 patients with implants in the anterior maxilla. You can see these are very old. These are hollow basket implants with actually a 15-degree angled head on them. But we put them deep in the tissue because we wanted to hide the margin between the crown and the implant. And that happens right near the bone. So I put these implants in very deep into the bone. And when we put a restoration on top, you can see that we lost bone because we were right on top of the bone. The top of the implant was right on the bone. We lost bone around it in the first 6 months very quickly once we created the interface up there. And then we followed it for 1 year, 2 years, 3 years, 4 years, and 5 years. And you see that really not much happens after that initial bone resorption. So if you look at what we did, this was the summation of all the patients that we did. Of the 27 patients, we put the top of the implant very close to the bone, on average about 1.5 millimeters above the bone. And in that first 6 months, we saw a dramatic change to 3.2 millimeters. And so the delta, the change, the bone resorption there was 1.7 millimeters because we had the top of the implant close to the bone. And so here you see 1.7 millimeters of bone loss in that first 6 months, and then it becomes stable because we're away from the bone at that point. Now, we also treated 15 patients that had edentulous mandibles. We put in 4 to 6 implants. Here, we left the implant sticking up right much higher because we were going to put a bar across there and do a denture on top of that. So we left the implant sticking up much higher in this case. So here, instead of 1.5 millimeters above the bone, these were 2.7 millimeters above the bone. In the first 6 months after restoring these implants, it went to 3.4 millimeters. The maxilla was 3.2. So the change here, the delta, is only 0.7 of a millimeter because we are already further away from the bone. So here we, instead of 1.7 millimeters, we saw 0.7 millimeters, and then we saw stability over time. So again, where you put the top of the implant, where you put that interface is going to make a difference. This is just a paper that was done in 2018 that kind of reinforced the same thing we found. This was a prospective multi-center study looking at crustal bone changes, 1-year findings. You see their conclusion was that implants that were subcrustally showed greater bone resorption than at the crustal level. So these same findings that we had and we created experimentally were seen by many, many other people. So why is that happening? Now, let me just take your mind off of implants for a minute. Ole did this as well with periodontal disease, and ask the question, can we do something about inhibiting that amount of bone loss? And so we published a paper. I have a very smart friend, a guy named Dana Graves. He and I trained in perio together. And Dana had been studying arthritis and the inflammation associated with arthritis. And he called me up one day and said, David, he said, you know, we've all been taught in periodontal disease that bacteria cause bone resorption in periodontal disease. He said, I don't think that's true. He said, I think the bacteria initiate inflammation, and inflammation causes the bone resorption. And he said, we're going to prove that. And I said, well, that's fantastic, Dana. I said, how are we going to do that? He said, well, you're going to get 15 monkeys. You're going to tie ligatures around their teeth. And then we're going to inhibit, we're going to put on one side of these animals, you're going to take a syringe and you're going to inject inhibitors to interleukin-1 and tumor necrosis factor alpha. These two are pro-inflammatory cytokines. They cause inflammation in our bodies. So interleukin-1, TNF-alpha are inflammatory mediators, and we're going to block those. So he went to the genetics company. They made these blockers or antagonists of these inflammatory mediators. We're going to tie ligatures around the teeth. We're going to put bacteria in their mouth. We're going to get bacteria everywhere. But on one side, we're going to inject into the papillas these blockers. And the other side, we're just going to do buffer. And the point was to show that inflammation causes pathologic changes, in this case, bone loss. So that's what we wanted to do, an interventional trial. And you know, if you show intervention, then it's cause and effect. You can show cause and effect. It's not association, it's intervention. So we did this paper, and what we did was when we looked at the histology, we saw that if we inhibited inflammation, we could block the number of osteoclasts there, and we could also block the bone loss in periodontal disease. So blocking inflammation was important. These inhibitors that we had, the antagonist, we could reduce inflammation, the inflammatory cells, those little blue dots I showed you, by 80%. We could reduce osteoclast formation by about 70%, and we could reduce the bone loss in periodontal disease by 60%. So reducing inflammation is key. It shows us that if inflammation is reduced, you can reduce bone loss. So where is inflammation around a dental implant? So we did this one paper where we looked at inflammatory cells along the side of an implant. And where was there inflammation? This paper in the Journal of Dental Research showed that there's a persistent acute inflammation at the implant abutment or microgap interface. Persistent acute. Persistent means that something's creating this continual inflammation by the host. And it's an acute inflammation, meaning it's polymorphonucleoleucocytes, PMN cells. So when we looked at that, we also looked at it if we move that microgap up or down closer to the bone, and it turns out the inflammation is associated with where that interface is. So if you move the interface away from the bone, the inflammation moves away from the bone. If you move it closer to the bone, the inflammation goes to the bone. So what we did was we looked along the side of these implants, and you can see that where the peak of inflammatory cells, those blue lines on the left, the peak of inflammation was associated with that microgap. That tells us that there's something going on in that microgap that's causing the host to react by creating inflammation. And we all know, and Dr. Jensen showed a really nice large microgap of 100 microns, that's where the inflammation is coming from, is the host is directing its response to that microgap. Now, I like to look at the microgap there like an infected root, an infected endodontic tooth. You know, when we have an endodontic lesion, there's bacteria inside the tooth, bacteria is coming down the root. The body cannot eliminate that infection, right? So what does the body do? It creates a cyst at the apex, right? And a cyst is an epithelial line cavity. So our host reacts to all infection by trying to wall it off with inflammation, and then it resorbs bone from the inflammation. And that's how we know it happens in every endodontically involved tooth, because that's how we react as humans to an infection. We try to wall it off with epithelium, and then if it's close to bone, the inflammation that's developed resorbs bone. And those little microgaps, the same thing. Remember how the epithelium always went past it? The host is trying to wall that off with epithelium, and if that inflammation is close to bone, bone's resorbed. If you have a tissue level implant, when we looked at under the microscope at those cells, the only inflammatory cells we saw were associated with the sulcus, which is what you'd expect. And these were mononuclear cells. These were more of a chronic type inflammation. So other people have shown the same thing. Here's Mark Quirinans, a periodontist in Belgium, showed there's microbial penetration at the implant abutment interface and butt joint interfaces with an external hex design. That was that typical Brandemark design. And these microorganisms grow into that microgap, create this bacterial reservoir, and it results in an area of inflamed connective tissue, which is what I showed you all those blue dots were. So it turns out, and this is probably the most important thing that I can probably show you today that I'd like for you to remember, is that there's a spatial relationship between inflamed connective tissue and bone loss. And there's tons of data about this. This is not new. This is Warhol in 1979 talked about this gingival inflammation and the extended arm, that it has an effect spatially. So there's a spatial relationship between inflamed connective tissue and bone loss. Phil Garant at NYU, effective radius of action of locally produced bone resorption stimulators. In this case, it turned out to be interleukin-1 was what they were talking about. And then my friend Dana Graves and I have talked about this as an inflammatory front, that when you have a critical level of these pro-inflammatory cytokines like interleukin-1 and TNF-alpha, these things are exactly what is creating this inflammation. So if you have marginal gingivitis, we have bacteria there, but as soon as that inflammation goes deep into the tissues, you can see, and this is what Ole talked about, from macrophages going from M1 to M2, they turn into osteoclasts and create bone resorption. That's what inflammation is. And there's a huge area of science. I won't get into this. I don't have time, but there's a whole area called osteoimmunology that talks about the immune system and the bone system. And there's substances called rankle that interleukin-1 and TNF-alpha stimulate rankle. Rankle causes bone resorption. This is, if you talk about this, it'll get the title, Inflammation-Induced Bone Resorption. You see these activated T lymphocytes on the left. Those are those blue dot cells that we saw around the inflamed connective tissue. They produce this substance called rankle that tells the macrophage to turn into osteoclast. And there's mechanisms throughout that cause the production of rankle and bone resorption. So we know it from healthy teeth, right? We're dentists, so we know if you've got healthy connective tissue versus inflamed connective tissue, we're going to get different reaction. Implants are no different. You create a microgap or interface on the bone level, you're going to get inflammation. And I won't go into this, but this TNF superfamily, the rankle production is what stimulates pre-osteoclast into osteoclast, and it resorbs bone. This has been shown over and over again, and we just need to wake up to this realization that if you have a lot of rankle, you're going to get bone loss, osteoporosis in this case. You can do it experimentally. So it's very important, the ratio of rankle to OPG, and when we see inflammation, rankle is high. There are several ways I think we can minimize inflammation around an implant. One, we can decrease the size and try to eliminate the microgap effect, if you will. If we eliminate a microgap, then we actually have a tissue level implant. But we can decrease the size, or maybe we can seal that implant abutment interface somehow, or we physically move it. And I just want to show you what we want to think about is decreasing inflammation. So we did a study to see if we could make the microgap so small, and Ole talked about this. So we compared a 10 micron microgap versus a 50 micron versus a 100 micron microgap. We did this histologically in this experiment, and then this was the radiographic paper on the same thing. And the bottom line was we were not able, even at 10 microns, to eliminate the bone loss associated with the microgap. So we couldn't, back at that time, make a microgap smaller than 10 microns, and 10 microns resulted in bone resorption. Now, what about platform switching? We've all talked about that and heard a lot about that. It really changes the architecture because we've shifted really the reaction against the bone. We've shifted that internally towards the abutment. So we did an experiment to see if that changed the type of bone resorption that occurred when we did platform switching. And this was the experiment, and we put, again, one of the implants above the bone, one below it, and one at the bone crest level. See if we could understand this a little bit better. We restored these animals with gold crowns. And here's a radiograph just showing you the different things. Type A was above the bone, type B was below, and C was at the bone crest. And I just want to show you the histology because it's really astounding here when you think about it. This is typically the way an implant looks histologically. Notice the threads. The threads are where the forces get distributed into the bone. And look at the trabeculae of the bone down in the bone marrow space. It's beautiful. This is Frost's law. Excuse me, Frost's law with bone. The bone reinforces where the stress is given out on the implant. But what I want to draw your attention to, here's an implant. Look at the top of the implant. The bone right up to the top of that implant. And then here's one that's placed below the crest. And I want you to focus on that upper left area at the very top of the implant. Because what you see here is something that we've never seen before in dental implants and histology. Look where the epithelium is. Look at the very top there. See, I have a pointer here. I'm going to show you on this right screen over here. The epithelium stops here. There's only connective tissue. There's no epithelium here. This is the first time we've ever been able to trick the body into not seeing a gap here, so the epithelium doesn't go past this. It stays up here. First time that's ever happened. But one of the things that we do have is we have a Morse taper, and Dr. Jensen alluded to this. Morse tapers result in a very stable connection. I'll talk about that for just a second in a minute. But I just want to show a high magnification of this. There is no epithelium over here. It's beautiful bone formation actually moving coronally here because there was a tapered burr to put this implant in with. You see osteoid, this little pink. You see these beautiful connective tissue fibers in here. This is woven immature bone. And then here's more lamellar woven bone with central canals and everything that we know from healthy bone. But there's no epithelium here. The body doesn't recognize this as a microgap. Very interesting. There's another one that you can see, and look at the healthy connective tissue. No epithelium along the surface up here on the upper right. So this was really a different relationship. Here's another systematic review, meta-analysis, if you will, from 2010, 10 studies looking at platform switching versus a butt joint type, what they call platform matched. And what they showed was platform switched had significantly less bone loss than the Breinemark type butt joint system. And if you look at the forest plot on these, you can see the summary statistic, which is that big black diamond down here, that favors platform switching. It's completely to the left. So a summary statistics of all those studies show there's a strong favoring of less bone loss when you have platform switching. So when we look at this type of relationship, it's something very different because the epithelium doesn't come down past these interfaces. Very different when we can stabilize that. Now, Ole talked about this just a little bit. This is this top one, 20 Morse taper implants, placed them in bacteria, gap sizes from 4 to 10 microns. Bacteria were found in all of these samples. If we look at another paper, which is 30 Morse taper implants, these were placed in E. coli, a different kind of bacteria. The endotoxin penetrated all the implants. So we did a little review in the literature, and we looked at 9 papers here. And every, I'm sorry, if I go back. Yeah, 9 papers here. You can see the external hex. Every paper that looked, they had contaminated interfaces. Even internal hex papers had contamination, and platform switch, 3 out of 4 had contamination of the interfaces, even in platform switched implants. Now these 9 papers from 94 to 2010, I'm going to show you 9 more papers that have looked at this, and they've looked at contamination. Here's 3 more on the external hex, all contaminated internal hex, and platform switched 8 of 9 in these studies. So the bacteria are still getting into these types of interfaces. So when we look at implant design and bone loss, the tissue level is the least. The most are when we have these butt joint external hex type connections. And then in between that is what platform switch is. So what we were seeing 30 years ago was clearly a difference between these types of relationships. You have a choice in that. This AO consensus paper confirms that there's differences, confirmed our findings, that there are differences. And what we learned about over time, particularly with the butt joint type interfaces, is when you do a second stage surgery, you put the abutment on top of the implant, you create an interface in here, bacteria get into that area and create inflammation. And if your implant's on top of the bone, that inflammation front is right on top of the bone. And we know then there's tons of data that that inflammatory front sitting on the top of the bone stimulates rankle production, osteoclast formation, and resorbs bone. And once there's a safe distance away from that infection and inflammation, then the bone loss stops. Now, Ole talked about Morse taper. Stanley Morse, long time ago, 1864, this is a principle of a cone and a cone. And the front end of most of our cars have Morse taper type connections to lock the parts together. And really a Morse taper is an angle between two cones of 1.5 to 3 degrees. Now, implant companies picked up on this. For example, the Straumann company uses Morse taper of about 8 degrees. It's Morse taper-like. It's not really Morse taper because it's not 3 degrees or less, but it's 8 degrees. The Astra system has an 11-degree Morse taper. But clearly, the more Morse taper-like angle that you have, the better off you're going to be. So the smaller the angle, the more stability there's going to be between the abutment and the implant. And it turns out, I believe that's really, really important. And then also machining makes a big difference. What is the amount of contact in your Morse taper? Is it a little bit or a lot? Obviously, the more you can get, the more stable you're going to have. So I just want to end with this, these two studies, just talk about them just very quickly. This is a very different type of data in implant dentistry. A fellow named Jan Dirks did these two papers, and it was a very interesting study. It turns out in the country of Sweden, they, in 2003, said they would pay for the patient's implants if you sent in the implant into a registry. And so they had about 25,000 people get implants in Sweden, and the dentist sent in the information about it. And so what Jan Dirks did was go in and pull out 2,700 charts and looked at what happened with those implants. There were about 11,000 implants in this case, and there were 3 predominant implant systems. There was a bone level from Astra, a bone level from Noble Biocare, and then a tissue level. And for our purposes, I want to look at this in relationship to bone level versus tissue level, just to reinforce what we've been talking about. And so if you look at the amount of early implant loss and the chance of losing an implant, on the left side there, you'll see that with the first bone level implant, you had about twice as greater risk of losing an implant early on compared to the tissue level implant. Same thing in that middle panel, the other bone level implant, about twice the risk of losing an implant compared to a tissue level implant. And if you got one of these other types of implants, that 10%, you had about 8 times greater chance of losing that implant if that's the implant you got in your mouth. If you look at late bone loss or late implant loss, you can see that with the blue or the red type of bone level implant, you had a 5 or 6-fold greater risk of losing one of these bone level implants compared to the tissue level implant. And then if you look at bone loss in this study, you had about a 3.5 times greater risk of losing 2 millimeters of bone around the implant compared to the tissue level. So I think we can say that tissue level implants, which lack a bacterial contaminated interface at the crest, compared to 2 bone level in an epidemiological study, had lower risk of early implant loss. It had they had earlier or lower risk of late loss, and they had a lower risk of marginal bone loss. So the question is why? And I think you've probably seen now that implant interfaces at the bone crest, when they're contaminated with bacteria, such as the butt joint interface, has a localized infection. We need to call it an infection that exists all the way around that implant, not just on the facial. And these local infections, which initially cause 1.5 millimeters of bone loss, exist in equilibrium with the host, right? And so when a complication comes, and Dr. Jensen gave you a number of other risk factors, that some of those risk factors, when they come in, that disrupts the equilibrium, as he talked about, and it creates more bone loss due to that inflammatory front. So these contaminated interfaces put the implant and restoration at greater risk for failure than implants without a contamination or without such interfaces at the bone crest, such as tissue level implants. And these are your choices. So there are 3 major types of implants, configurations at the bone crest. There are documented biological consequences to each of these. And the host, our bodies react in a very similar way to all of these, and we can predict what that's going to be. And these experiences in a national population support the use of tissue level implants. So I started with this slide from this meta-analysis of greater than 45,000 implants, asking the question, why? And it's very clear that it's due to inflammation, that the bacteria close to bone in the interfaces create inflammation in our bodies. Inflammation causes bone loss. When that inflammation is close to bone, we lose that bone. Unfortunately, this paper from the AO never mentioned the word inflammation. It's really frustrating to me after 30 years of working in this area, with all the data that you just saw about inflammation and bone loss, that the authors didn't acknowledge that that's what's going on and causing this type of bone resorption. But it is what it is. You guys now have heard this, and hopefully you'll go forward with it. But clearly there's differences in the reactions around implants, and you and I have a choice to make when we put these in our patients, and we can determine how much bone loss occurs. So Mike, thank you so much. I'm so sorry
No,
for
you're
going
good,
late.
you're good. Don't leave yet. Don't leave yet.